And the first session will be anatomy. I think it'll be a good start for all of us to refresh our knowledge, and we have the anatomy demonstrators who are working at Nuffields. We have 4 of them, and I'm excited personally to hear this talk because I know they've put a lot of effort into it. It's far more effort than I put into my slides. Where are you guys? Chi, George, Ian and Sarah.
Okay, good morning everyone. My name's Chioma and I'm here with my colleagues Sarah, Ian and George. And as Mr. Almafood said, we are anatomy demonstrators as well as doctors at the Nuffield. So it's rightly so that we're going to be talking about spinal anatomy this morning, and hopefully by the end of the talk you'll realise what all the fuss is about. A little bit disclaimer before we start. We realise that there are some experts in the field in the audience, so you may find the talk a bit basic, but nonetheless I hope you enjoy it, and at the very least it will be a nice overview and recap before we get on with the rest of the day. Okay, so spinal anatomy is important because if we have a good understanding of that, we're able to diagnose spinal disease appropriately and therefore manage it correctly, or in the best way that we can. So we're going to look at the vertebral column and the spinal cord in detail, and then go on to discuss some applied anatomy. So essentially, the vertebral column is a chain of 33 bones, which are known as vertebrae. Each vertebrae is separated by the intervertebral disc and then joined together by various joints, ligaments, and muscles. So if we look at a typical vertebrae here, on the right we are looking at it from face on, and on the left we're looking at it from a side view. So anteriorly we've got it works. Anteriorly, we've got the vertebral bodies, and these are essentially the weight-bearing component of the column. Posteriorly, we've got the vertebral arch, which is here, and between the two, we've got the pedicle. Altogether, this forms a vertebral foramen. If we look closely at the vertebral arch, we've got the transverse processes laterally, and the spinous process which projects backwards in the midline. There we go. And then between the transverse process and the spinous process lies the lamina. And on either side of the midline, at the junction between the lamina, transverse process and pedicle, are the superior and inferior articular processes. So essentially, each vertebra lines up to form a column, and it does so in a way that the vertebral foramina form the vertebral canal, which is also known as the spinal column. This contains the spinal cord as shown in this diagram, and therefore protects it. In addition to protection, the vertebral column is the central axis of the body. It facilitates or maintains posture and allows for movement. It also supports the weight of the body above the pelvis. Before we go on to look at each section of the vertebral column, let's look at the vertebral discs. So these are the shock absorbers. On the outside, we've got a fibrocartilagous ring, which is known as the annulus fibrosus. And essentially this has high tensile strength and extensibility. So it's able to withstand, shear torsion essentially. If we look in the middle zone, where the light blue is there, we've got a gelatinous, which is essentially a hydrated gel that is known as the nucleus pulposus. This is able to withstand vertical compression. Looking at the ligaments, so this diagram just shows a cross-section, so this way, of the vertebra with the ligaments attached. So anteriorly, in the reddish orange and pink, we've got the anterior longitudinal ligaments and the posterior longitudinal ligaments. These essentially run along the course of the vertebral bodies, and the anterior longitudinal ligaments it's a fibrous band, and it essentially prevents hyperextension, like so, of the spine. The posterior longitudinal ligaments prevents hyperflexion, so if you were to bend too much forwards. The ligaments associated with the arches is the ligamentum flavum. that essentially extends between each of the laminas. So it's in the light blue on the diagram, and it has high elastin content. So it essentially elongates during extension and shortens during flexion. The green and the orange, and yellow, sorry, is the interspinal ligament and the supraspinous ligament. These are attached to the spinous processes. So in the green, you can see that it's attached to the spinous process more in the middle, and the yellow is attached to the tips of the spinous process. The two work together, and essentially let's just make sure I tell you the correct thing. I don't want to get it wrong. The spinous ligament, it becomes taut during flexion and then lax during extension. So those are all the ligaments. So as I've said, the spine moves. So when we have two successive vertebrae, which are associated with the discs and the ligaments, they're known as the functional units. These units, can I go back? Yeah, okay, cool. These functional units are essentially exhibit the biomechanical characteristics of the entire spine. And what that actually means is each unit moves and is stabilized in the same way that the entire spine moves and is stabilized. So it's a nice way to break down what the spine actually does. So some spine biomechanics. Essentially, this is the movement of the spine. So the spine is able to flex, extend, move in the lateral flexion direction, and then rotate. So, interestingly, each part of the spine does this to a different degree, and this is facilitated by the joints, which specifically the facet joint. I know I've mentioned that before, but that is the meeting point between the inferior and superior articular processes, which I described when we were looking at the vertebrae. Sarah's going to go on to, really break down the different characteristics of the column, but it's important, as the theme of today is lumbar and lower back pain, it's important to remember that the lumbar part of the spine has increased range of movement, essentially flexion and extension. Therefore, it's common to see degenerative changes in the general population. Over to you, Sarah.
Thank you, Chi. My name's Sarah, and now that she has gone through the function and structure of the vertebral column as a whole, I'm going to go into more detail about the 4 regions of the vertebral column. So, back to basics. We'll start with the cervical spine, which has 7 vertebrae labelled C1 through to C7. Next down, we have the thoracic spine. We have 12 vertebrae labelled T1 to T12, followed by the lumbar spine, L1 through to L5. And these 24 vertebrae make up the movable part of the spine. The sacrum and the coccyx at the bottom, they are fused vertebrae, so they are not movable. And as you can see from the picture on the left, the vertebrae in each section don't look exactly the same. They each have distinctive characteristics, and that's related to their function. And one of our favourite things to do to stress out our medical students in the dissection room is we've got a box of random vertebrae, and we'll give it to the medical students and ask them to pick one at random and tell us where in the spine it comes from. They really don't like that exercise. But I'm going to teach you in the next few slides how you can do that exercise and complete it. So, first up, we have the cervical spine. As I said, there's 7 vertebrae in the cervical spine, and there is exactly 7 in all mammals. So even if you're a giraffe with a very, very long neck, you still have 7 vertebrae exactly. There are 3 main distinguishing characteristics for your cervical vertebrae. There's this bifid spinous process here. So you can see at the back, it bifurcates into 2, which is very characteristic. You also have this, there we go, transverse foramina. So this is really important because that's where the vertebral arteries come through the spine and supply the brain. So they come off the subclavians, come up the posterior aspect of the spine and supply the brain. Very, very important structures. Lastly, we have this triangular vertebral foramen. So that's where the spinal cord is going through. It's in this distinctive triangular shape. There are, of course, exceptions to this. For example, C1, the very first cervical vertebrae, is very distinctive looking. It's called the Atlas, named after that Greek god, the Titan god who held the world over his shoulders. One of the only interesting anatomy names that we have. And that doesn't have a vertebral body or a spinous process. It's really just two arches and some small bones on the side. Moving down, we have the thoracic spine. So we have 12 thoracic vertebrae which are associated with 12 ribs. And the distinguishing characteristics of the thoracic spine is very much related to its function articulating with those ribs. As a result, we have these demifacets. There are 4 demifacets on each vertebrae. There's inferior and superior on both sides, and these articulate with the head of each rib. We then have these costal facets on the transverse processes, and these articulate with the shaft of each rib. So there's this very intricate process connecting the vertebrae to all the ribs. Next here we have these characteristic spinous processes, which are inferiorly, posteriorly, and obliquely orientated. And finally, we have our vertebral foramen, which is typically circular. Moving down further, we now have the lumbar spine. This is characteristics in its lack of characteristics, so it doesn't have any transverse foramina, bifid spinous process, anything like that. It is, however, very large, and that's unsurprising given that it's got to support the weight of all of the torso. So you've got these large vertebrae which are supposedly kidney-shaped. I think that does require a bit of imagination if you see it in person. But they're large, they're kidney-shaped, and they have a triangular vertebral foramen, much like the cervical spine. Finally, we have the end of the spinal column. We have the sacral spine and the coccyx. The sacrum is this collection of 5 fused vertebrae in an inverted triangle shape, which articulates with the coccyx, that small bone, which is also called the tailbone. And that's the one that, if you look at some researchers, they'll argue that it's evidence of evolution, evidence that we used to have a tail. Okay, this is my last slide before I hand over to George and Ian. I'm just going to very briefly go through the curves of the spine. So as you all know, if we take a slice of someone's spine from the sagittal plane, it's not going to be a straight line. It's going to have curves, and it has curves because that helps with shock absorption. So the same way if you have a spring and you compress the spring, it won't break. The spine has curves so that it can absorb shock without injuring itself. You've got these primary curves that are present when you're born. They're called the thoracic kyphosis and the sacral kyphosis. You can see those backward C shapes on the diagram. Then you have these secondary curves. So these develop from standing upright and supporting the weight of the torso and the head. They're called the cervical lordosis and the lumbar lordosis. Of course, these are supposed to be balanced to maintain your desired posture, but they can become imbalanced, which is where you get all of you coming in. Okay, thank you.
So good morning, everyone. Thank you very much, Sarah. So I'm going to be talking about the spinal cord. Together, so we'll discuss a little bit about the position and structure, the meninges, and talk about the spinal nerves as well. So together with the brain, the spinal cord makes up the central nervous system, and it extends inferiorly from the medulla oblongata, the bottom of the brainstem, all the way down to terminating at L1, where it continues thereafter as the filum terminale. The filum terminale attaches to the coccyx, and this anchors the spinal cord and the meninges. You can see on the picture there's a cervical enlargement. So here the spinal cord gets slightly larger, and this corresponds with the origin of the brachial plexus. And the lumbar enlargement, also there on the picture, corresponds with the origin of the lumbosacral plexus. So the components of the central nervous system are covered by meninges, which are sort of membranous covering, and they act to support and protect the spinal cord. If we look at it more closely, we've got 3 layers. So we can see the dura in blue on the diagram. So this is the outermost layer of the meninges. In the skull, the dura is actually comprised of 2 layers, a periosteal layer and a meningeal layer, with a venous sinus in between. But this terminates in the foramen magnum, and in the spinal cord, there's just 1 layer of the dura mater. So in order for the spinal nerves to leave the spinal canal, they must pierce this dura. You can see where it transitions from being blue into yellow. And here the dura is continuous with the outer covering of the nerves, and we call that the epineurium. The next layer is the arachnoid mater. So you can see this on the diagram as being red. This is an avascular layer which contains the CSF. That's the target of a lumbar puncture. The final layer is the pia mater, which is a very thin layer of the meninges, which is very tightly adhered to the spinal cord. And in between nerve roots, the pia thickens to form denticulate ligaments, which act to suspend the spinal cord in the vertebral canal. So if we now look at a cross-section of the spinal cord, nerve fibres in the cord are grouped together in tracts, a bit beyond the scope of this talk. But essentially, fibres from descending tracts exit the spinal cord ventrally, so at the bottom of this diagram, and they exit through a ventral route, and fibres which are ascending enter the spinal cord through the dorsal route, which you can see at the top of the diagram. This dorsal route and ventral route combine to form a spinal nerve, and the spinal nerves are mixed, so they contain afferent and efferent fibres. The spinal nerves are actually quite short because they split very soon into a dorsal ramus and a ventral ramus, the ventral ramus being much larger than the dorsal ramus. So the ventral ramus does most of the work, supplying mixed innervation to kind of the ventral trunk. The dorsal ramus is much smaller and supplies mixed innervation to the synovial joints of the vertebral column, the deep muscles of the back, and the overlying skin. So considering spinal nerves allows us to discuss one of the fundamental concepts of the spine, which is that of dermatomes and myotomes. So a dermatome is an area of skin innervated by the dorsal root of a single spinal nerve. And a myotome is a group of muscles innervated by the ventral root of a single spinal nerve. And why do we care about this? Well, it's a good question, and that's sort of where you come in as the multidisciplinary team. So having a robust understanding of these dermatomes and myotomes allows us to match up the clinical signs and symptoms that patients present with to the level of spinal pathology, and then able to target our treatment and management on that basis.
Thank you very much, George. So I've been tasked with the last bit of the presentation title with a bit of clinical relevance. So why is this all important? So approximately 80% of the population will get some sort of back pain at some point in their lives. So that's quite a lot, and also there's a lot of drainage to the NHS and the healthcare service as well. So most common cause for lower back pain is generally degeneration, which also leads on to herniation as well. And not surprisingly, from Sarah's talk as well, the lumbar spine is the most common area of herniation or degeneration, and that's because that's where most of the burden is put through axial loading and our normal load-bearing activities. So that's generally L4, L5 and L5S1. This diagram shows generation quite nicely. So as we get older, our cells get old and stop repairing so well, and also stop making certain proteins which help with water retention, which is important in our discs. Hence why in children and young adults, they have higher water content in their discs, which is why the disc is a bit thicker and also more flexible on radiographs. So going down, the general dehydration would cause disc collapse, which in turn causes strain on the fibrous ring, which then causes tear and cracks, and then herniation as well. Other events such as trauma, falls or car crashes can also speed up this process. So we have to delve into the lower back pain history that people often describe. they would say they have radicular pain. That affects more than one nerve root, causing pain, loss of sensation, also motor function deficits. They would also say about weakness and also sensory abnormalities in the lumbar sacral nerve root regions and distribution. And also they might find that flexion around the trunk is also a bit limited as well. They often say that pain is exacerbated by straining, coughing and sneezing. That's because that increases pressure in the spinal canal. So next bit, just a bit of risk factors. So factors that might increase the risk of herniated discs. So male around 20 to 25 often have increased risk. They tend to stereotypically go to the gym for heavy use or lifting improperly. And also people with obesity and increased weight, because that's because you put more load on your lower back. Occupations that require heavy lifting and also driving can cause that too. Driving, surprisingly, is from the vibration in your vehicle that over a long period of time can cause degeneration. Smoking is believed to reduce the oxygen and the nutritional supply to the discs, which causes rapid degeneration as well. So just a bit of knowledge about the clinical anatomy is quite important because it helps you, from George's talk about the dermatome and myotome, can pinpoint where the root cause is and where the pain's coming from. So just focusing on lower back pain today, so the dermatome that we normally look at would be the L4L5, which corresponds to the anterior lower leg, and then the L5S1 would be the posterior lower leg. And then myotome-wise, which is innervated by the ventral root, L4L5 would be the extension of the thigh at the hip joint, which is on the top left there. L4 to S1 is dorsiflexion of the foot at the ankle joint at the bottom, and also L5 to S1, which is the abduction of the thigh at the hip joint, which is on the right there. So when we talk about back pain, have to put in certain red flags, and corticoid syndrome is something that we need to just be mindful of when we're looking at back pain. So as George mentioned earlier, the spinal cord ends around T12L1, and essentially it's corticoid group of nerves and nerve root, which is distal to the spinal cord, which typically lies about L1 to S5. The symptoms are caused by compression. Some extrinsic factors can sometimes be abscesses, spinal stenosis, tumours, and also trauma. The symptoms, sign of symptoms would include urinary and fecal incontinence, urinary retention, so not being able to go to toilet, decreased anal tone, saddle anaesthesia, progressive neurology, which is normally unilateral or bilateral in the motor and sensory fields, and sometimes reduced and absent reflexes. It is a medical emergency and normally requires urgent attention, but we would normally see this in the acute hospitals normally, and it requires urgent MRI and urgent decompression in hopefully 24 hours, but no later than 48 hours. And just to wrap up, looking at the indication for lower back surgery. So generally we would operate on lower backs if they failed non-operative management, so that's either oral medication or physiotherapy. If they have leg pain and or motor deficit impairing their quality of life, if they have progressive neurological deficit, which is leg weakness or numbness, and also if they've lost their normal bowel or bladder function. So that wraps up our talk. We would open the floor to any questions, and thank you very much for your time.